Okay, we have two talks left. Our next talk will be on disaster and evacuation response. This will be presented by Colonel Stacy Shackelford, who is an instructor at the Air Force Trauma and Training Facility in Baltimore.
Thank you very much. I'm actually a maximally invasive surgeon, so it's kind of an honor to actually get to present here at SAGES. It's my first time. So what I'm going to talk about today is really the pride of the Air Force Medical Corps and something that has really revolutionized the way that we take care of our casualties. Really, air evacuation of injured soldiers has been around as long as we have used aircraft in warfare. The first large-scale operation started in World War II, where we evacuated over 1 million patients in that war. The record for a single day was over 4,700 patients evacuated. Flight nurses and flight surgeons were trained, and we really began to develop the concept of care in the air. The Korean War, 1950 to 55, during this war, we saw the advent of the helicopter evacuation from the point of injury. Pilots could land at the point of injury, pick up a casualty, get them to surgery very quickly. The Bell H-13 was actually nicknamed the Angel of Mercy because they evacuated so many casualties, over 18,000 casualties in that conflict, and really pioneered emergency helicopter evacuation that's in commonplace use today. The next war, the Vietnam War, 1965 to 75. At this time, the casualty received sophisticated care in country. And then when they were very stable, from there they were evacuated by air to either the Philippines or Japan, where they continued to receive state-of-the-art care and eventually were transported home. And this system brought the patient home in an average of 45 days from the time of injury. A critical incident occurred in 1983. This was the Beirut bombing at the Marine barracks in Beirut, Lebanon. This incident produced a large number of casualties and really brought to light a number of challenges that we faced. In this particular incident, surgery was delayed beyond 12 hours. They really had no ICU level care available to transport these patients. They had to transport them all the way to Germany. And there was a lot of after-action reports that came out of this event, and they really realized that there were significant opportunities for improvement. After that, we really started to develop a new approach, which was based on the patient being the mobile part of the system. And we developed the capability for critical care air transport, routine transport of ventilated patients, which is really built around the air ambulance model. And here you see what we call the Cadillac of Air Evac, which is the C-9 Nightingale. They trained and equipped evacuation teams, and the Nightingale flew many successful missions throughout the 80s and the 90s. In the 90s, we began what we called the Expeditionary Air Force, and this was really a complete restructuring of the way that we do our deployments, kind of taking us out of the Cold War era into the modern age of deployments. And this really meant that the entire force was structured into deployable modules that could be bags packed, ready to go at very short notice. And in order to meet this new requirement of this sort of light, mobile force that we were developing now, we had to really, really downsize our hospitals. And we developed a modular component. We had small teams that could be expanded to the right size and tailored to really meet any capability needed. Also in the 90s, on the civilian side, we saw the evolution of damage control surgery. And this was really based around the concept of the lethal triad, and really came to the forefront in 1993 when Dr. Rotundo coined the term damage control surgery. It was recognized that this concept could be applied not only to rural trauma, but also to trauma in the military setting. And it really became the standard of care, with the urban trauma centers leading the way at that time. So it was really in the late 90s when all of these factors merged together. The idea of damage control surgery, the Expeditionary Air Force, and at the time we also had a Surgeon General who was a general surgeon, General Carleton, and he really had a huge impact on changing the way that we take care of patients. And what came out of this was a new platform with small, lightweight, mobile medical units combined with rapid evacuation of patients, even while still in the resuscitation phase of their care. And so our modern trauma system is based around these concepts of rapid helicopter evacuation from the point of injury, followed by damage control surgery, and then evacuation to progressively higher levels of care with en route care, which encompasses resuscitation during transport. All of our hospitals now are based around several ideas that the hospital needs to have maximum resuscitative capabilities, but very minimum holding capacity, which makes them highly dependent on evacuation. You've seen that Matt showed this slide a little earlier about the way that our trauma system is set up now, but a couple of things just to highlight is that all of these levels of care, from role 1 all the way through role 5, are tied together by air evacuation. From the lower levels of care, we'll typically use helicopter evacuation, which is more frequently run by the Army. And between the higher levels of care, from role 3 to 4 and 4 to 5, these are the long-range transports, which are really run by the Air Force, and have led to an incredible change in the way that we treat our patients. And this particular system, the way it's set up now in Afghanistan and the way it was set up in Iraq, brings our casualties home from the point of wounding to that time that they arrive back in the continental US in an average of 3.5 days. So just in order to illustrate how this system works, let me just introduce a typical patient. This can be Sergeant Johnson. He's a special ops soldier. He was actually standing on a roof, and he was shot up from below. Even though he was wearing body armor, it didn't provide much protection from that direction. And he sustained a bullet wound, entered through the perineum, injured his bladder, the sigmoid colon, his spleen, and went into the left chest. He came to us I was working at the level 3 at that time. He looked about like this. He was operated on by a general surgeon, assisted by an orthopedic surgeon. He'd had those bladder repairs, as you can see listed on his belly, a sigmoid colectomy. They took out his spleen. They packed his pelvis for bleeding. He had a chest tube and a temporary abdominal closure, as you can see. He was placed on a helicopter within an hour after his surgery and flew on a 1-hour flight to the role 3. Once he got to the role 3, he underwent some warming and resuscitation, and the following day he went back to the OR where he underwent washout. They removed his packs. He had a colostomy performed. You can see there's a temporary abdominal closure there as well. And so now we have this guy in the ICU, and the plan is to move him on to Germany, which is about a 7 to 8 hour flight from CENTCOM, and it may actually take up to 3 days, though, if they get diverted. They always plan every trip as a 3-day flight. This is now done routinely, but moving this type of patient was actually a huge challenge when we first started doing it. And just to point out some of the challenges that the evacuation team will face, right here, you can see he has an endotracheal tube, which has a air-filled balloon cuff. He's on a ventilator, and the ventilator needs to continue to function through multiple transfers and at altitude. It needs to be powered on the aircraft. He needs to have oxygen to last the entire flight. We need to be able to track blood gases because he's on the ventilator. He has a chest tube, which needs to stay with him during transport. He's got an open abdomen, a wound vac. He needs monitoring system, sedation to last the entire flight, IV access. Probably he's going to need dressing changes. He may bleed. He'll definitely have ongoing resuscitation needs. And by the way, now we can't even afford to fly the air ambulance anymore because it's extremely inefficient for large-scale operations. So basically, we have to fly him on what is essentially a delivery truck, or what we call an aircraft of opportunity, which is the next available aircraft leaving theater. So they bring in supplies, they unload supplies, they reconfigure the aircraft, and they load patients and fly back the other direction. much more efficient, but brings to light very difficult challenges for the evacuation team. And it's not always the same type of aircraft. They really have to be prepared to load on any type of aircraft. Here's what it looks like on a C-130. And just to kind of describe some of the challenges that they face. Temperature is a big problem. It's cold at altitude. When they're on the ground, it can be very, very hot. The military aircraft aren't insulated the way commercial flights are, so it's extremely loud. This is a stressor for the patient, and also a challenge for the team to communicate, and you can kind of forget about hearing any of the alarms on the monitors. Hypoxia, the cabin is pressurized to about 7,000 feet, unlike the air ambulance, which was pressurized to sea level. Humidity, insensible losses are very high. Gas expansion, so things like endotracheal tube, balloon cuffs, the pressure bag, if you have an arterial line, any trapped gas in the body, like a small pneumothorax can become a large pneumothorax. Acceleration effects are not insignificant. Our combat takeoff and landings are quite a bit more exciting than commercial airlines as well, so that can create additional changes in the patient's hemodynamic and their intracerebral pressure, for instance. The space is very confined. It's not like taking care of a patient in the ICU. And these are very long missions, so the evacuation teams have to stay alert the entire time. The answer really to meet these challenges was the CCAT teams. These were really developed in the 90s and have been very, very well trained. The team consists of a critical care doc, an ICU nurse, and a respiratory therapist. And normally, these teams can take up to 3 stabilized but critically ill patients. Stabilized means they must have a secure airway, they must have hemorrhage control, and they must have their fractures immobilized. So that doesn't necessarily mean they're physiologically stable, and resuscitation will continue en route. These guys are also trained to load on every aircraft in the Air Force inventory, and every aircraft creates unique challenges to the evacuation team. They carry all their own supplies. Here you see this is the equipment that is needed for one mission. ICU nurse here is loading the patient for transport. You can see on the right side there is the ventilator, the left side's the IV pump, oxygen, wound vac, there's a ventriculostomy, all of these things loaded onto the patient's stretcher there for flight. Another patient, this is a kind of a common injury pattern with multiple extremity wounds, open wounds, and the wound vacs. One of the big challenges is getting this type of critical care equipment approved for flight is a huge challenge. It took us actually about 5 years to get approval to use these wound vacs in flight, and these are one of our more critical wound management systems that we use. On the aircraft, major pitfalls to avoid. Anatomic trapped gas, so this could be anything from pneumocephalus, pneumothorax, or something like a bowel obstruction. This gas expands at altitude and can lead to a dramatic worsening of the patient's condition. Unsecured airway, the loss of an airway can be fatal in flight, particularly if it's, say, like a burn patient or someone where it can be difficult to get re-secure the airway. Fluctuating mental status, if the patient has a fluctuating mental status and is difficult to control, requires some sedation, and then loses their airway. I mean, this is a huge challenge in flight, so sometimes better just to put these patients under anesthesia or keep them sedated the whole time with intubation. Worsening pulmonary status, huge problem in flight, especially considering the hypoxia at the altitude. Bleeding is extremely difficult to address in this environment, and considering the fact that we're transporting these patients very, very early on after surgery and very early during their resuscitation process, there really is significant possibility of rebleeding. Compartment syndrome, injured extremities in particular are at risk for worsening edema in the altitude environment, hypobaric type environment that we have at altitude. To date, we've transported about 70,000 patients, evacuated them from theater, and about 3,000 of those have been transported by CCAT, or critical care missions. This slide shows improvements in killed of action, died of wounds, and casualty fatality rates since World War II, And with casualty fatality rates, this actually represents the number of patients who died after reaching the hospital alive. And you can see it went from about 19% World War II, 16% Vietnam, and 10 to 13% roughly in the current conflicts. This improvement is even more remarkable when you consider that we've rapidly transported, even faster and faster, sicker and sicker patients to the hospital. And in spite of this, we've still seen this dramatic improvement in survival rates. There's been multiple factors that really play into improved survival. Number one is improved armor and improved vehicles, rapid access to resuscitative surgery, and rapid evacuation to higher levels of care. For a future direction, this will really kind of parallel advances in technology. There's a lot of work going into automated life support systems, which could potentially adjust oxygenation, ventilation, but maybe even such things as IV fluids, IV drips, et cetera. Decision support monitoring is monitors which can analyze the physiologic trends and the waveforms and help provide early decision support or early detection of patient deterioration, much more so than is currently available today. In many ways, we don't know what we don't know, and one of our big issues has been charting and data collection and a central CCAT registry. So it's very, very, huge effort underway, which is sort of like a better late than never type of effort to really improve our ability to capture data during en route care. And we're looking at the role of advanced resuscitative teams at the point of injury, which is putting physician and nurses and advanced paramedics closer to the point of injury where they can really affect care immediately on the battlefield. And a lot of interest in looking forward to future conflicts where it's really not a developed theater of war like we have in Afghanistan, where every patient is going to have the benefit of Role 3 care and a CAT scan before they get on a long-range flight. And there's going to be a lot more unknowns during en route care. Really like to thank SAGES for their support of the military and the opportunity for us to really share lessons learned in this forum. Thank you.